Thanks very much, Alan. That is only well received because it was shorter than most of the others. I just want to say right at the beginning in disclosures that there was no involvement of pharmaceutical companies at any stage of the development of the BAP guideline, and that although I do talk about this and the National Audit of Schizophrenia data as well at a number of drug company, pharmaceutical company run meetings, I don't accept honoraria for doing that either. I should also say that we've just been funded for the next round of what you knew as the National Audit of Schizophrenia, but will now be the National Clinical Audit of Psychosis. So come September, we'll be persecuting you who are general adult psychiatrists for lots of data. Weight gain is the sort of title of this particular presentation, and of course weight gain has two different lots of consequences. First of all, it's increased your risk of metabolic syndrome, obesity, insulin resistance, hyperlipidemia, increasing risk of type 2 diabetes and cardiovascular disease. And of course, deterioration in appearance may well be a factor in non-adherence with medication as well. Data from lots of different studies, but this is data from one of Mark DeHert's reviews and compilations of data show that, in schizophrenia and very similarly in bipolar disorder, prevalence of obesity, smoking, diabetes, hypertension, dyslipidemia, metabolic syndrome are all quite high and relatively higher than in the general population. And of course, we know that mortality in schizophrenia, and I'm focusing more on schizophrenia because that's where there's probably more comprehensive data. Mortality in schizophrenia is increased. Life expectancy from the age of 20 years is lowered by about 22 years. Data partly from Tohonen's study, but a lot of other studies as well, including a long-term follow-up study in Southampton by Brown and colleagues some years ago as well. And the increase in mortality is particularly due to cardiovascular disease. So these things like obesity and development of type 2 diabetes are important because they're frequently antecedents of that. Interestingly, in the Tohonen study, and the reason I'm sort of using this data rather than perhaps some of the other data on mortality, is that they looked in their sort of population study at whether people had been receiving no antipsychotics, low doses, moderate doses, or high doses of antipsychotics. So being prescribed an antipsychotic of itself wasn't something that was increasing your mortality. Indeed, actively treating the illness was likely to cause benefit you compared to people with schizophrenia who weren't being treated with antipsychotics, but nevertheless still within the group of people with schizophrenia, of course, there is increased mortality. Of course, we've got a lot of risk factors for that among this population of patients. Smoking, obesity, diabetes, and alcohol misuse, which I think we often forget about. Obviously, I'm going to focus today more on issues around obesity and weight gain. And the factors driving weight gain are in part poor lifestyle and physical inactivity, often poor diet among these folk. Effects of antipsychotics, some of which seem more likely to contribute towards weight gain than others. Also, individual pharmacogenetic differences. For example, if you've got a particular variant of the promoter region for the 5-HT2C receptor, you're more likely to get weight gain with a drug like olanzapine than if you have a different polymorphism. And there's also evidence that insulin secretion may perhaps be interfered with to some degree by some antipsychotic medications. So there's a number of factors that may drive weight gain. And of course, another problem is, do we assess people adequately for these risk factors, and then do we intervene if we actually find there is a problem? And we know from audit programs like National Audit of Schizophrenia, Prescribing Observatory for Mental Health that Tom Barnes and Carol Patton have been running now for, nearly must be 10 years. All of this data suggests that we don't monitor adequately. Indeed, looking at all the risk factors that you'd ideally want somebody to have monitored, we found in both the first and second round of the National Audit of Schizophrenia that only just around about 30% of people were getting all of the relevant factors monitored. And if you look just simply at body mass index, at BMI, only about 55% had their BMI measured in the previous 12 months. We've also got to look probably at use of risk prediction models for cardiovascular illness, because that may determine some aspects of how we manage the problem of increasing cardiovascular risk, whether it's from obesity or other issues. And I suspect in psychiatry we're not so good at using those perhaps as for example, our colleagues in primary care. QRisk2, which is available free online, is a reasonable risk assessment tool to use. But it is worth bearing in mind that there are some limitations in the population of people with psychosis, and it's worth looking at data from the Primrose study by David Osborne, who's a psychiatrist, academic psychiatrist at UCL. And David is in the process of trying to produce a sort of a risk model which may be of more use to us in psychiatry in general, but certainly for people with schizophrenia and bipolar disorder and depression, in that he finds that there are slight differences in the model he has been developing and is trying to finally validate before suggesting it goes into use. Slight differences from QRisk, but he would say that for the time being, QRisk is certainly a very reasonable model to use. As Alan said, I'm going to talk about the BIP guidelines. These were drawn up by a multidisciplinary group, which include general psychiatrists, pharmacists, general physicians like Adrian Heald and Richard Holt, who's written a number of the UK diabetes guidelines, and psychologists who've been involved in running healthy living programs for people with psychosis, and Elizabeth England, who's the RCGP mental health lead. To start off with, and briefly, but I think it's worth just going over what we should be doing in terms of monitoring. Our view was that you should monitor BMI, and I put in here, note, not waist circumference. Waist circumference obviously is good from an academic perspective if you're looking at aspects of weight gain. It's measuring abdominal fat more so, which is what creates the risk for cardiovascular disease. But if you look at the NICE guidelines for management of obesity, it's BMI is what they recommend. Waist circumference is useful as a secondary measure if you want to subclassify within wider groupings of BMI. But BMI is something that's straightforward, that most people can manage to measure their weight. Measuring waist circumference is more problematic. And I can tell you from the National Audit of Schizophrenia, we got a range of BMIs returned on people from 18 centimetres to 180 centimetres. So some of the data was clearly completely wrong, and it certainly didn't correlate with any BMI data we got on patients, and only about 10% of patients that seem to have waist circumference data available anyway. So we sort of recommend BMI, which obviously should be looked at relatively frequently early on, because a lot of people get their weight gain early on, and you need to start intervening at that point. Something people don't always realize, that if your BMI is above 35, then waist circumference becomes completely unreliable anyway, and many of our patients do have quite high BMIs. Glucose control in the long term, internationally, WHO and other guidelines now say HbA1c, but remember that in the first 12 weeks or so, HbA1c will not help you. You need to do either fasting or random glucose at that point, because it takes some weeks of abnormal glucose levels before HbA1c will begin to reflect that. Lipid profile, fairly standard, but if you're going to use a model like QRIS2, then you need the cholesterol HDL cholesterol ratio to enter into that. And these days, they say you don't need a fasting sample, a random sample is adequate for that. And also, tobacco smoking and alcohol use should be inquired about, because this is important in relation to cardiovascular risk. Again, a problem with CG178, the schizophrenia guideline, is that it really only talks about monitoring alcohol use in relation to mental state and mental well-being, but it is important as well for physical well-being. So, to focus now really on interventions about weight gain, interventions for smoking and alcohol misuse and so on, hypertension, probably don't differ, in necessarily in a huge way from the general recommendations for those things. And details about our view on that in psychosis is in the published guideline. But what about interventions for the weight gain and development of obesity? It's important to remember that most of these RCTs that we've looked at examine the effects of an intervention versus placebo or other appropriate controls. So sometimes that's treatment as usual. Sometimes it's just a sort of maybe a brief bit of advice about weight gain. It does vary between studies. Majority of trials of pharmacological interventions often include some form of lifestyle approach, so it may be that everybody in the trial is getting some low-level lifestyle approach, and then half are getting a pharmacological intervention and half are getting a placebo treatment. There are some studies in people in their first episode of illness, but not all that many, and they look at attenuation of weight gain versus standard regimens. I mentioned earlier, most of the data we've looked at is in people with schizophrenia because it's more limited in other areas. We also didn't specifically look at under 18 populations or learning disability populations. There are specific issues there, but for under 18 age populations, the general advice regarding management of weight gain probably remains pretty much the same. Obviously, in people with learning disability, there can be a whole variety of other reasons for weight gain, which makes it more complex, but there are also no randomized controlled trials of particular interventions in that population. What you find is, and these are the four approaches that we've recommended in the guidelines, is lifestyle interventions, antipsychotic switching, adjunctive aripiprazole, or adjunctive metformin. Or I should say these are the interventions we recommend you at least consider. You get about 3 kilograms of weight loss, whatever you do, whichever of these you do. But remember, that's a mean. And as Alan was mentioning earlier in relation to cognitive aspects and mood disorders, there's a range. So some people may be getting quite significant weight loss, whereas some may have relatively little or still have a small amount of weight gain. But for lifestyle interventions, the mean's about 3 kilograms, antipsychotic switching 3 kgs, aripiprazole is about 2 kilograms, adjunctive metformin, again, it's about 3 kilograms. If you gain weight, if you gain more than 7% of your initial body weight, that increases your risk of diabetes by about 14%. And if you're going the other way and looking at weight loss, then what's regarded as a clinically significant weight loss is a 5% weight loss. And another problem with many of these trials is they don't tell you what proportion of people have lost 5% of body weight. They'll tell you the change in kilograms, the change in BMI, whereas really often what you want to know is what proportion of people have lost 5% of body weight in the active group versus the control group. I'll show you some data relating to that, but most of the trials, unfortunately, don't give you that data. Now, lifestyle interventions. NICE guidelines, of course, both recommend these as the initial approach to weight gain. It's also recommended in the NICE guidelines on prevention of diabetes in people who are at high risk of developing diabetes in the general population, us. Content of these sort of programs, it's some or all of trying to get people to improve their eating behavior, reduce energy intake. Some are group sessions only, some of them are individual sessions in these trials, some are both. The evidence slightly suggests that doing both is more helpful than one or other on its own. Attempts to improve quality of diet, attempts to increase physical activity, and often some element of counselling or cognitive approach to help people understand their eating behaviours. At a general population level, can these kinds of programs help? And there's probably been a number of these in different countries. One, for example, was the 20-year North Karelia project in Finland, where there's a 20-year program to influence smoking as well as diet and exercise, which resulted in a 59% reduction in coronary heart disease. So there's some evidence that at a wide population level, this kind of thing can be helpful. Now, before I show you the meta-analysis data for lifestyle interventions in people with severe mental illness, let's look at the use of these interventions for obese adults in the general population. And this looks at 44 studies that had at least 12 weeks of follow-up, and the folk recruited to these had a BMI of at least 30 kilograms per metre squared, and another morbidity risk factor when they entered these studies. Yellow is the people who had diet plus physical activity. Brown is diet alone. Blue is physical activity alone. So studies with analyzable data at 3 months, you can see that diet plus physical activity was pretty much the same as diet alone, but physical activity did very little for you. 6 months, 12 months, and 24 months, this pattern more or less continues. You see that diet plus physical activity versus diet alone is relatively similar. Physical activity showing a bit more effect at 6 months, but not at 12 months and 24 months. So the message here really is that diet is the key to getting people's weight down. Given that a lot of our population of patients aren't always terribly good at engaging in physical activity because it may involve having to be with a lot of other people and they may find that difficult and all sorts of other reasons. Diet is in terms of the general population, is clearly the effective element. Now, I'm not saying people shouldn't be encouraged to take part in physical activity regimens. There's certainly evidence, both in the general population and in our population of patients, that improves cardiovascular fitness, for example. But if we're looking at weight loss, then diet is probably the key thing. This is a meta-analysis of studies, 25 studies across a variety of countries, USA, UK, Europe, Australia, South America, Far East, China, and so on. Variable lengths of follow-up. 14 of them were less than 3 months, 7 3 to 6 months, only 4 out to 12 months. And this again is another problem with the literature in this area. Many studies are relatively short-term follow-up for something that is a long-term problem. So you have to bear that in mind. But overall, the effect size, looking at standardized mean difference here, this was a statistically significant benefit of intervention versus control treatment. But you can see there are studies here with a sort of a variety of outcomes. Some have done better than others. These are alphabetical. This isn't by time, so it's not a time effect. This is the top one here in purple is a study in folk with first episode illness, so you can see that it's effective there as well as in people with established illness, so lifestyle interventions useful right from the start. This one, the DOMET study, is the largest study, 144 people in the experimental group, 147 in the control group. At 18 months, the mean difference was weight loss of 3.2 kilograms in the intervention group. 37, almost 38% lost more than 5% of weight, but in the control group it was still 23%. So you still see improvements in your control groups. Though, as I mentioned earlier, most of the control groups in studies like this still had some form of intervention, but not as intensive an intervention as in the active group. What about other measures of cardiovascular risk? Well, waist circumference went down in the active group, triglycerides went down, fasting glucose went down, insulin levels went down. Across this meta-analysis, there were no overall changes in levels of cholesterol and no overall changes in blood pressure. But when you look at these kinds of studies, you have to be careful in how you interpret blood pressure data. Remember, you're really only interested in blood pressure dropping in people who've developed pathologically high blood pressure. So not everybody who's entered in these studies has been developing high blood pressure. And again, one of the drawbacks is that none of the studies actually tell you how many people got high blood pressure and who therefore needed to reduce it. Most people on antipsychotics will get some drop in blood pressure because a lot of the drugs are alpha blockers. So you have to be a little bit careful about interpreting lack of changes in blood pressure in this data. This particular meta-analysis separates out what might be called prevention trials, where lifestyle interventions were introduced right from the start in first episode treatment programs, against intervention trials where people who'd been long established in antipsychotics were given a lifestyle intervention. And you can see that the effects are pretty much the same. About a 3 kilogram weight loss is the mean weight loss across both groups of patients. So these treatments are useful from the beginning as well as in the process of treatment. Now, what I'm going to show you here is data from an American study, 200 patients, 170 completers at 12 months, 2 facilitators, weekly meetings for 6 months with the patients in the active arm, increased awareness through monitoring of diet, physical activity and sleep, creating personalized diet and physical activity plans, reducing calories, getting people to reduce portion sizes, getting them to increase consumption of fruit and veg, increasing their physical activity, developing action plans for high-risk eating situations, graphing progress, helping people to make adjustments, addressing mental health effects and life change efforts. I'm not sure quite how you manage that in today's NHS. It's a lot, and you know, as I say, two facilitators. It's quite intense. The data from this particular study over 12 months. The brown group is the active intervention group, and you can see that this intervention produced, you know, quite a marked drop in weight from about 108 kgs to just over 104 kgs, which then was pretty well maintained at that level over the second 6 months of follow-up. The control group showed a slight increase in weight initially, but then did later drop a little bit, though even at the end here, there is still a significant difference between the two groups at the 0.004 level. But this is also a trend you tend to find that, you know, if you look short term at 3 months, 6 months, there's quite a big difference between treatment group and control group. At a later stage, that difference does often narrow to an extent, but is usually still statistically significant. So to summarize, in relation to lifestyle interventions for weight gain, these clearly can have a positive effect in reducing antipsychotic weight gain. There's evidence that they work in first episode psychosis. Data for glucose, lipids, and blood pressure do vary between studies, but in general, the trend is towards improvement, and particularly in plasma glucose. There's no clear evidence from these studies about how often you need to meet with these individuals. Is it weekly, fortnightly, monthly? What should be the duration and intensity of these interventions? There's too much variability across studies to really address that. But probably most of these are meeting with people at least every couple of weeks in an initial phase, and then maybe monthly for a period after that. Again, you can see that the differences between the intervention and the control group can narrow after a while, and it's quite likely that booster sessions in the long term may be necessary. What about switching antipsychotics? Antipsychotics can be a driver for weight gain, and we know that some antipsychotics seem to have a lower potential for inducing weight gain than others. This really rank order is produced from the meta-analysis of Stefan Lucht that was, I think it was Naomi showed that earlier today. So there may be some logic in considering a change from a drug that has a high potential to induce weight gain to a drug with lower potential, or certainly in first episode folk, to consider from the start a drug with lower potential for weight gain. The problem, of course, with this is that this is an indirect network meta-analysis of all these drugs. And I should say that Stefan Lucht's analysis, of course, only looks at oral medications. It doesn't include long-acting injectables. And again, most of the data I'm talking about today is about people who are on oral antipsychotics rather than LAIs. So it can be difficult to interpret all of this, because some comparisons that are made between drugs in this kind of analysis may relate to only 2 or 3 studies. And of course, it's all related back to how these drugs compare to placebo or haloperidol as an active comparator. The problem is that there are very few studies being carried out where these drugs are compared with each other purely to look at the issue of weight gain or weight loss. There are quite a number of direct comparisons between drugs that have been done to look at differences in symptom control, and in general, those show the same kind of pattern you see here in terms of weight gain and weight loss. But there are only actually 4 studies that have been done that are direct comparisons, direct RCTs, purely for the purpose of looking at the effect on weight. Those 4 RCTs support switches from olanzapine to either aripiprazole or quetiapine, which sort of fits with this sort of general schema from the indirect meta-analysis of Lucht. And that's not to say that these are the only switches that might be useful. I think we have to go back to this to consider what switches might be useful in a particular individual. But in terms of specific RCTs, there is very limited data available, unfortunately. It's important to remember we need to balance possible benefit of a switch with risk of inducing clinical relapse. And we also have to remember that the new medication, even aripiprazole, can induce weight gain in some people. So we have to warn folk about that if we're going to switch them for the purpose of weight loss. Now, I mentioned earlier that effects at, say, 5-HT2 receptors may be one reason why some people get increase in body weight on certain antipsychotics. if we look at these left two columns, you can see here a study where rats have been given either a non-active vehicle or vehicle plus olanzapine, and that results in a massive increase in food intake over the following 60 minutes in those animals. But if they've been pre-treated with aripiprazole, you see a different effect. Animals who've been given aripiprazole alone show no increase in food intake, but interestingly, animals given olanzapine plus aripiprazole show a marked decrease in food intake compared to those given olanzapine alone. So it's clear that in this situation, aripiprazole, at least in an animal study, can be protective against the effects of olanzapine. Now, this isn't a 5-HT2 mechanism, it's some other mechanism, and there are a variety of people like Gavin Reynolds and others who are investigating what other mechanisms might be important in weight gain. Interestingly, this same effect of aripiprazole has also been observed in laboratory animals with ziprasidone and lurasidone. So this gives you a kind of theoretical background for considering why it might be worth adding aripiprazole to an antipsychotic if somebody's getting weight gain with that antipsychotic. There have been a number of case studies which suggest that's worthwhile. It's become quite common practice in some centres. There are only actually 3 RCTs that properly address the issue. 2 of these are additions of aripiprazole to clozapine in patients who gained significant weight in clozapine, and 1 is an addition of aripiprazole to olanzapine. The only study of significant size is the Fleischhacker study, which had 107 people who got aripiprazole and 99 controls. But if you do a meta-analysis of the effects of adding aripiprazole in relation to weight gain across these 3 studies, we see a weight loss of about 2 kilograms. And the data is pretty consistent for each of these studies. For fasting glucose, there's no significant difference, but there was a decrease in HbA1c, decreases in cholesterol and LDL, no change in triglycerides. But you have to remember that these results are driven mainly by this very large Fleischhacker study, the other 2 studies being relatively small. And this shows the difference in weight from baseline. This is the placebo treatment group. This is the aripiprazole treated group. So you can see there's a progressive and significant loss of weight. They reported the percentage showed a weight loss of more than 7% rather than the more traditional 5%. Placebo, only 3% lost more than 7% of weight, but the aripiprazole group, it was 15%, had a clinically significant loss of weight. So to kind of summarize regarding aripiprazole, there's case reports in non-RCT studies suggest adding it to either clozapine or olanzapine may be worthwhile. 3 RCTs show consistent benefit. There's no evidence that doing this results in deterioration in symptoms, and indeed there is one study that looked at aripiprazole as an adjunct to clozapine to try and improve symptoms and showed there could be a slight improvement. So there's no risk of causing deterioration in these patients, but remember that it is polypharmacy, which can lead to increased other adverse effects, and it is off-label prescribing. The doses used in these RCTs are between 5 and 15 milligrams a day of aripiprazole. Finally, metformin, which is perhaps the most controversial of these kind of approaches. Metformin's an oral glucose-lowering drug. It's the first-line drug for treatment of type 2 diabetes in UK and virtually all international guidelines for the management of diabetes. But one of the things it does in diabetes, as well as other things, it stabilizes body weight, And in those at risk of developing diabetes, people at high risk of getting type 2 diabetes, it reduces progression to diabetes and reduces weight. And of course, the population of folk we're dealing with who are gaining a lot of weight, often starting to get abnormal blood glucose, are people who are at high risk of developing diabetes. So I'd like to mention really some data in relation to the general population again before we look at meta-analyses of the effects of metformin in people with psychosis on antipsychotics. First of all, there's the relatively large UK prospective diabetes study group, 753 people followed up for over 10 years, given metformin or treatment as usual. These were people who are at high risk of developing type 2 diabetes. There was a reduction in all-cause mortality in this group, and particularly reductions in cardiovascular type mortality. The US had a similar study, the Diabetes Prevention Program, which was a massive program involving over 3,000 people initially. The initial follow-up was just under 3 years, and that was a double-blind of lifestyle versus metformin versus placebo. And then there was an open follow-up for up to 10 years, which the majority, something like 85% of these folk participated in. And these people got reduction in weight, but reduction in weight was greater in the lifestyle group compared to metformin in the initial phase, but then the two groups converged. I'll show you detailed data from that study just in a moment. The other thing worth bearing in mind is NICE guideline Public Health 38, PH38, which is about type 2 diabetes prevention in people at high risk. This is the general population, not people with psychosis, but in the general population, adults at high risk whose fasting glucose or HbA1c shows they're progressing towards type 2 diabetes, and who have either failed with lifestyle programs or are unable to participate in lifestyle programs, should be considered for prescription of metformin to reduce the risk of developing diabetes. If that's applicable to the general population, it's equally applicable to our population of patients, though we often forget about that. This just shows you the risk of the cumulative incidence of development of diabetes from the US Diabetes Prevention Program. So the turquoise is placebo group, the red is the metformin group, and the purple is the lifestyle group. So you can see that if you take all participants, which covered, I think, ages from 16 to about 65 or 80, I can't remember exactly the top end. But you can see that lifestyle does a bit better than metformin in preventing development of diabetes, but both do better than placebo, and these are statistically significant differences. But what we're perhaps interested in is this subgroup, age 25 to 44, and a number of different age cohorts were pulled out in the analysis of this study in the Lancet. And you can see that for the 25 to 44-year-old age group, which is our group with, developed psychosis, who are just gone on antipsychotics in recent times, for this group, metformin and lifestyle interventions were pretty well equal in terms of preventing development of type 2 diabetes. I could show you relatively similar data for weight gain as well. The interesting thing is that when they look at compliance with treatment, those who comply well or moderately well with their metformin treatment are doing as well as the lifestyle group and have very significant effects in terms of weight loss. However, to turn to our folk, this is a meta-analysis of metformin studies for weight gain in people with schizophrenia and schizoaffective disorder. And again, you can see that there's an overall significant effect in favor of metformin with a mean difference of about 3 kilograms again. So this is 10 studies, China, Taiwan, Venezuela, Iran, and USA. Now, you do have to be a little bit careful about studies in China and Taiwan because initial body size, initial BMI, and so on will be lower in those populations. But these, so you know, a 3 kilogram difference is a lot more for a Chinese person very often than it is for a Western European. But these studies included follow-ups up to 24 weeks, which is quite good in this area of the literature. Although 4 of the first episode studies, there were 4, but 3 were from the same research group. So again, there's perhaps not quite as much replication as you would like in that area. This shows another study that was published since that meta-analysis, published in JSACA-Pharm, just showing the effects of 66 South Asian patients, I think mainly Indian, randomized to 500 mg of metformin twice a day or placebo, 6 months, 58% completed. Mean difference at the end point was 2.5 kilograms, strongly statistically significant. Do remember, though, that metformin can have adverse effects. Main side effects are GI and relatively minor for most people, but renal excretion accumulation can lead to lactic acidosis. So if EGFR is low, then metformin is contraindicated. And over time, it can reduce absorption of vitamin B12 as well, as you can see here. So finally, as far as metformin is concerned, nice recommendations for people who are at high risk of developing type 2 diabetes in the general population are that you should consider it. It's probably a bit less effective than lifestyle, which should be tried first, but it's something that we should be considering. But again, remember that this use in prevention, whether it be in people with psychosis or the general population, is off-label. The dose of metformin used in RCTs is around 750 to 1,000 milligrams a day. Finally, I want to mention a clatter of treatments for which we didn't think there was sufficient evidence or any evidence to suggest their use, but you may have been aware of some of these being used to try and manage weight gain. First of all, there are ones in which there has been data available from RCTs and antipsychotic treated patients, and I'll look at some of that in a moment. There are drawbacks in that. And you may consider some of these drugs after considering the other 4 treatments, but there are limitations. There are drugs which are on treatments like bariatric surgery that have been shown to be useful in the general population, most recently naltrexone bupropion combinations, but as yet there are no trials in people with psychosis or people on antipsychotics. There are drugs that have been withdrawn from treatment, most often because of some cardiovascular adverse effect. Some of them showed effectiveness, most of them actually at the end of the day didn't, so we can cross those out. And there are a number of drugs for which there have been negative clinical trials. These are available in the UK, but clinical trials haven't found evidence of effectiveness in reducing weight gain. So just to mention briefly Group A, the evidence base for most of these is small, like zonisamide, I think, has either 1 or 2 studies. It's a relatively new anticonvulsant, although it looks interesting. Topiramate has 4 or 5 studies, and a meta-analysis of these suggests it can be effective in reducing antipsychotic-induced weight gain, but cognitive impairment can be significant with topiramate, and given that a lot of our folk are already cognitively impaired, that is really probably against it. Orlistat, which interestingly the Joint Royal Colleges report suggested should be used, Orlistat only has evidence for effectiveness in males. It's not effective in females. And when you talk to GPs and physicians, they say, if you can get people to stay on Orlistat for more than a year, you're doing very well. About 3% of people stay on it for a year. So may be okay short term, but again, only in males. No evidence for value in females who are on antipsychotics. So, as I say, you can't really say there's a lot of evidence for these. Reboxetine, there's a couple of studies, but they're both from the same research group, and I'm not sure that the second study published doesn't include patients from the first study, so there's a bit of uncertainty about it. Bariatric surgery is an interesting one. There are no specific studies in people with psychosis, but surgeons who have big bariatric surgery clinics have published case series which will often include 3 or 4 people with either schizophrenia or bipolar disorder. The evidence from those is that it's as effective as it is in the general population, without significant adverse effects in terms of rehospitalizations or anything, but again, it's very much individual case kind of data rather than controlled trials. So I just leave you, as say, with the reference to the guidelines. This is available free from the BAP website, and if you're interested in this area, please download. Thank you.
So we've got time for 1 or 2 questions. With topiramate, Steve, the cognitive impairments, rarely you get this very severe cognitive impairment.
With topiramate?
Yes.
Yes.
But the average cognitive impairment is relatively...
The average cognitive impairment is probably relatively small, although interestingly, if you look in clinical trials in epilepsy, cognitive impairment is the biggest reason for patients to stop treatment.
Okay. Frank?
Question to that. In a study that we did at topiramate, the weight loss was very much related to the dose of the blood level of topiramate, and almost certainly so with the adverse effects. So what you said is absolutely right. You're going to get effects of topiramate, you're probably going to get other adverse effects. And word finding problems in particular can be very, very problematic with topiramate. So when people ask me, would I prescribe topiramate? Absolutely not.
I must say that topiramate has got some evidence in binge eating, and I have used it in binge eating, and it actually seems to be very effective. But that's slightly, I mean, it's obviously related.
It's used a lot in the States, and most of the trials are in the States. And interestingly, used a lot in adolescents with psychosis who are getting massive weight gain in the States.
Well, doesn't seem there's many questions. Oh, lady there, a final question from you.
Hi there. It's more, excuse me, an observation, which is, I'm wondering if your review of so weight management, metabolic side effects, reflected on the kind of ownership of this, because there's a big problem between psychiatric services, GP services, non-attenders, and how we get clarity over ownership of it, because I think everybody agrees monitoring is a very good idea, but making it happen is another one.
Yes. My last slide that I flipped through very quickly kind of alluded to that and said that obviously from the BAP point of view, you can't give advice about that. It's very much a matter of how individual trusts and primary care liaise together. Certainly speaking from the National Office of Schizophrenia perspective, the massive problem is the lack of data linkage between us and primary care. We find that only 25% of people have their blood pressure measured, but if you ask the patients in the service user survey, 80% of them say their blood pressure has been measured because it's been done in primary care by the practice nurse. So there's a huge gulf there, which is part of this problem of managing this issue then of weight gain and cardiovascular risk. It just reflects an aspect of that. Clearly the CG 178 guideline says that we've got to manage these risks in the first 12 months, and then it's a question of an agreed handover to primary care. But I agree, it's very, very difficult to necessarily get fully taken on by primary care. Primary care probably depends very much on the practice nurses. Try to get practice it virtually doesn't happen. It's extremely difficult. So there's a massive problem in there, I agree. And I suspect it's one of those things that can only be tackled at a local level, because we have engaged with, we did engage with our CGP, and through NAS we've had good engagement with our CGP, but it is very difficult even at that level to take ownership. I think when Peg Gerardo was president, there was more ownership being taken, and since she's no longer president, I think there's been a bit of a drop-off in interest, is my impression.
Well, we're going to have to stop there, but I'd like to ask you all to join me in thanking not only Professor Cooper, but all today's speakers. Thank you very much.